Hello, my name is Anil Bangu. I'm a consultant colorectal surgeon in Birmingham in the United Kingdom. I'm also the chief investigator of the CHEETAH Trial. Thank you very much for taking part in CHEETAH, and we are honoured and humbled that you are becoming part of this international team that is delivering this multi-country trial. CHEETAH is a cluster randomised controlled trial, and the following slides will introduce what that means and how it can be set up and introduced in your site. So thank you once again for watching, and we're really looking forward to working with you as part of a team to deliver CHEETAH.
Surgical site infection has been prioritised by the Global Surge Network as an important area to study. In the Global Surge 2 cohort study that recruited over 12,500 patients, surgical site infection rates after abdominal surgery were generally very high, but were higher in low and middle income countries than in high income countries. This has been published in the Lancet Infectious Disease under the Global Surge Group's name. This led to the design of the Falcon trial, which is currently being delivered across the hubs and spokes of the Global Surgery Network. This tested specific interventions at the time of surgery that included different types of skin preparation and coated versus non-coated sutures at the time of fascial closure. CHEETAH is the second trial within this portfolio. The primary objective of CHEETAH is to test whether changing gloves and using separate sterile instruments before closing the abdominal wall reduces surgical site infection for clean contaminated, or dirty abdominal surgery. These are the secondary objectives, and they include surgical site infection at discharge, readmission in 30 days, reoperation in 30 days, length of hospital stay, and death. CHEETAH is a cluster randomised controlled trial. Whereas most surgical trials are individually randomised, that is, the patient is randomised to an individual treatment, within CHEETAH, team behaviour is changed. Because it's the whole scrub team who will be changing their gloves and changing their instruments, once teams and surgeons have been trained, they're unlikely to go back to a different type of practice. Therefore, it's the hospital that has been exposed to the intervention. Because of that, it's the hospitals that are being randomised, not the individual patients. So within CHEETAH, it's the hospitals that are being randomised, and CHEETAH needs a minimum of 4 hospitals per country to achieve balance. Each of the patients going through the hospital will be exposed to whatever that practice is. So the control group, it will be the current routine hospital practice, and in the intervention group, it will be a change of gloves and instruments at the time of fascial closure.
CHEETAH is a big trial. It will need 12,800 patients in total. These patients will be recruited across 64 clusters. Since each cluster is a hospital, that means 64 hospitals. The target for each participating hospital will be to recruit 200 consecutive patients. There is some flexibility over this target, and some hospitals may recruit fewer than 200 patients.
These are the patients that will be included within CHEETAH. The patients will be all those undergoing an abdominal incision greater than 5 centimetres and have a clean contaminated, or dirty wound. For CHEETAH, caesarean section is excluded. All patients during surgery should have a World Health Organization checklist completed. Also, an operation note should be completed immediately following the procedure. All other intraoperative processes will be determined by the surgeon and anaesthetist, and these will be recorded. That includes other measures used in the hospital to prevent surgical site infection. If some surgeons change their gloves or they change their instruments, this will also be recorded irrespective of the hospital's randomization.
Follow-up in CHEETAH is performed at 2 time points. Firstly, the day the patient is discharged. Follow-up should be completed by a trained wound assessor and done in person. This wound assessor does not need to be blinded to the hospital's randomization. Secondly, the patient is followed up at 30 days following their operation. We recommend that this is done via the telephone using the script provided, and this is the time to assess the primary endpoint for all patients. This primary outcome measure is 30-day surgical site infection rate as according to the CDC criteria, which is defined within the case report forms. This is the crucial measurement for the primary outcome and is vital for completion of the trial. Individual patient-level consent for the specific CHEETAH intervention is impossible because the hospital is randomised and not the patient. Thus, consent is only required to collect 30-day follow-up data. This consent should be sought at the 30-day time point. If you're phoning the patient, this can be done using verbal consent over the telephone. If patients are coming back to hospital, a written consent form is provided. In summary, CHEETAH is a multi-centre, multi-country cluster randomised trial where the hospital is randomised to either their current routine practice versus a routine change of gloves and instruments at the time of abdominal wall fascia closure. Each hospital will recruit 200 consecutive patients having clean contaminated, or dirty surgery with an abdominal incision of greater than or equal to 5 centimetres. Patients are followed up at 30 days by the telephone with verbal consent taken at the time of that phone call.